Hello everyone. This is another domain for part 3 exam is regarding the communication with patient. So it's very important domain. You will be assessed how to communicate with the patients. Can you imagine that there are courses here in UK for only the communication, because especially if you are overseas and with a different language may be difficult. If you want to communicate well with the patient, there will be some language bridge between you and the patient. Sometimes even if you are fluent speaking English, there are some common faulty mistakes in the communication. We need to know how to communicate with the patient in according to the station. Okay, so for each station, don't forget to introduce yourself. That is the first thing you need to know. If you didn't introduce yourself to your patient, that will give a bad impression from both the patient and the examiner. So usually the name of the patient will be written in the station outside the cubicle, so you will know the name of the patient before you go inside the cubicle. So once you go inside, you say hello, don't say hi, because hi is not an official word. Officially, we will say hello. So you go inside, say hello, I am Nisreen. I'm one of the doctors in the clinic today. Okay? And then ask her politely if she can confirm her name or age, or you can ask her, is it Sarah June, for example. Okay? Um, Sometimes if the station is fine, you can tell like nice to meet you, but that doesn't suit some stations, like if the patient is having intrauterine death and you come today to discuss with her some options. You can't tell her nice to see you today or nice to meet you today. It's not nice actually. Um, Also, if she is in real pain and she's crying, you can't tell her nice to meet you. This situation is not nice, you know. So that's one of the communication things. You need to match the situation or to be aware of the situation. We call it situation awareness. So before you go inside, you have to expect how you will find your patient and to communicate with her accordingly. Okay. One of the good communication thingy is just to save the patient name in your head and keep repeating it all the time while you are explaining or giving the options. I know, Sarah, this is very difficult situation you may have passed through, but let me explain to you in a simple way. See, Sarah, uh, if we think about it like that, okay, so you include her name in between your talk. That's a very good thing with the communication. Actually, the communication has many types. So the first thing is the verbal communication when we speak to the patient. So we need you to be very confident in the exam, because if you are hesitant in speaking or not concentrating well on what you are talking about, that will not give a good impression from the examiner side. Okay, you have to be fully confident and speaking strongly in a confident speaking voice. Okay, you speak and listen. Don't take the hand of speaking throughout the station. You need to allow the patient to express her feelings. You need to allow the patient to tell you in her own words. So you have to be active listener. So you speak confidently, and then you have to be an active listener. What is the meaning of active listening? So if you ask the patient any question, can you tell me more about your periods, for example? Okay. And then she started to speak, and then you are not um, like oriented to her. You are not looking at her face, you're looking anywhere else or reviewing your notebook. That is not active listening. Active listening means that you show to the patient that you are really following her speech, sometimes with nodding your head, that you understand what she's telling you, and waiting to know what else she needs to speak. And even eye to eye contact can be part of the active listening. So that's very important. And don't interrupt the patient. So, for example, she's telling you, I have pain here, it's not relieving by any medication, and like that, like so. Don't stop her. Let her finish whatever she's wishing or willing to tell you. Okay? Until she finish everything, then you have to reply to her concern. So that is the meaning of active listening. Okay? Um, one of the verbal communication skills is to use a simple language. Um, we don't need to uh, make things difficult. We need to make things easy and simple. So, for example, if you are explaining to her what are the benefits of uh, delivering you by C-section, for example, is just to deliver your baby safely through a cut in your tummy. It's very simple, you know. We can't tell her we will take you to theater, we'll make a low transverse incision and then a lower segment incision in the uterus. That's very complicated to the patient. She doesn't need to know all these details. She just need to know that the delivery of the baby will be through a cut in her tummy, and that's it. Okay, so we need to use very simple language just to explain to the patient, and avoid medical jargon. And that's why we need to know the patient language, which is the lay language. What does this mean? So the patient can understand the medical terms. We need to change our language while we are speaking to the patient with the same language that the patient speaks. So from where we can get these terminologies, um, you can go through the patient information leaflets on the RCOG website. They will explain you everything. So you go one by one and read them carefully. You will find the thingy which will replace the medical jargon. Okay, like the word uterus in the medical terminology uh, equals womb in the lay language. Okay, the cervix equals neck of the womb. Doing ARM equals breaking your water. Okay, so you have to speak to the patient with the language that she can understand without any medical jargon, and that is the use or the effectiveness of continuously practicing this language at the moment. So your duty is to just practice with the lay language as much as you can. But be careful, this language only can be used in the patient or simulated patient task. But in the structured viva task, there is examiner who understands the medical jargon, so you have to switch your language in that case. So while you are speaking to your examiner or your colleague in teaching station, for example, you use the medical terminology as you used to. But while you are speaking to the patient, you can't use the medical terminologies. You have to use the lay language. The patient has to understand everything in a simple way. Um, One of the verbal communication skills is to watch your voice tone. What is the meaning of voice tone? So if the patient is very happy of something, you give her great news and she's very happy, so your tone of voice should change to suit the situation. Like, oh, congratulations, you got what you needed, like that, okay? But if the patient came to you, you want to deliver for her bad news, like you have a diagnosis of, for example, any cancer, or you want to deliver for her the news, your voice tone should go slowly in a manner that it is not like, uh, from your voice tone, I can feel that you are sad. You are sorry to tell that news, Rebecca. Um, I'm really sorry to be the bearer of that bad news, but I have lots of information to tell you. So, do you need any support from outside to be with you? I'm really sorry. The histology result doesn't seem um, that it's a good news. Unfortunately, there is some sinister cells in your womb, and it is suggestive that it is an invasive cancer. Okay, like that. So the voice tone itself will completely change the situation. Okay. Um, Yeah, so one of the verbal communication skills again is to call the patient with her name frequently. We mentioned about that, and assessing her understanding. That's while you are talking all the time, patient is listening to you. She didn't speak or she didn't show whether she's understanding. You have to stop in between and ask her, "Are you following me? Do you understand what I'm telling you? And do you have any questions so far?" That's very important in the communication. So you have to explain to her, for example, if she's coming with miscarriage and she's coming for to know her options. So you start with expectant management. This is the advantages. This is the disadvantages. The second option is the medical management, and this is the advantage. This is the disadvantage. The last option is the surgical management. And this is the advantage. And then she's just listening to you like that. But no, in between each one, you have to stop and ask her whether she's understanding well, and shall we carry on? Do you have any questions so far? Um, Sometimes you may give her a signpost, like before you speak, like if you think that you will take long time in counseling or giving the options of treatment, you can tell her, I will tell you all the information, but at any point, feel free to stop me if you want to ask about anything or you need any further explanation about any point. Okay? So that's to protect yourself if you forgot to assess her understanding. But it's better if you ask her all the time, do you understand what I'm talking about? And do you have any questions so far? So inviting a question as well is very important verbal communication skill. And the last thing is to respect the patient wishes. What does this mean? So the patient coming today, she has a previous C-section and she is coming to request another C-section. She doesn't want to try with VBAC. Okay, in your like what I mean, that you are convinced that VBAC is the best option after C-section because it's successful in 75% and it is less hospital stay, faster recovery time, all of that, so you recommend all the patient to have a VBAC. But this patient, she doesn't want to try VBAC, okay? So do we insist on giving her a VBAC? No, no. We have to respect her wishes. Yeah, I can respect your wish. We will do whatever you want. The decision is yours. But I need to explain to you all the benefits and risks of choosing an elective C-section versus trying a VBAC or a vaginal birth after C-section. So you explain to her all the possible risks and the benefits, and she has to weigh the information, and the decision is hers. The decision completely is up to her. Since she understands the risks and she is competent enough, she has the capacity to understand and sign the consent, then that's fine. We can respect her wish and will do whatever she chooses. One patient came to you, she have prolapse and she's unfit for surgery and she's declining pessary. Will you put a pessary for her? Never. You can't, because we need to respect the patient wishes. So what can we do if that is the case? So in this case, we need to try to convince her to do the lifestyle modification, the physiotherapy. We refer her to the urogyne clinic and see how things are going. And then if she's not convinced with a pessary, we need to chase with the anesthetist to see how fit she is for surgery and if we can optimize her condition and arrange a surgery as a last resort. But because the patient doesn't want this option, we can't give her that one. Okay, so that's very, very important in the communication, is to respect the patient wishes. So most of these are verbal communication. What about the non-verbal communication? Can you communicate with someone without speaking to him? Yes. So the first thing is the eye-to-eye contact. The mother is communicating with her baby through skin-to-skin contact, and we are communicating with our patient through eye-to-eye contact. How? So if I feel the patient is in pain, I have to maintain my facial expressions that I am feeling sorry for her. And sometimes I can tell her, oh dear, I'm really, really sorry for that pain you have now. It must be hurting so much, like that. So that's how to be emotionally. So notice how emotions feel physically. If the patient is happy, you have to smile, you have to be happy and congratulate her once the baby is out. Oh, congratulations, you got a little boy. Oh, have you got a name? Like that. If the patient is very worried, you have to make some impression that you are also worried. And if it is something reassuring, then you tell her, don't worry, I feel you are a little bit worried. No, I just need to reassure you that everything is all right, like that. And if the patient is sad, like she lost her baby or she has some sort of problems, like in her delivery, she developed any complication, then um, we need to look sad as well. And then we tell her, we are really, really sorry. I understand how you are feeling, and uh, I can see that it's very difficult to be tolerated, and you know, I'm really sorry, and I'm here to help you, like that. You know, you can just with your facial expressions is not only the verbal communication. You have to communicate with her non-verbally. So eye to eye contact, we need to keep it all the time. Don't look at the examiner, don't look at your notebook. Just see the patient, how she's speaking, how she's talking. And this is the non-verbal communication, which is very, very important. One of the non-verbal communication is when you deliver a bad news to the patient and she started to cry, don't speak at all while she's crying. You have to wait for her, okay? And try to give her tissue, try to give her cup of water, and wait until she calm down, and then sometimes the patient will be okay, you can go ahead. Or if she, like, you know, if you feel that she's spending lots of time in doing this drama and you will lost your time in the station, you can tell her, I'm really, really sorry. I understand how you are feeling. If you feel yourself unable to talk today, we can just stop here and arrange another appointment to speak about your options, if that's okay for you. Then at this moment she will stop and she will wait for you. Okay? She will ask you, no, I no, please doctor, go ahead. I want to know my options right now, like that. Okay? So if you feel that she's exaggerating too much and wasting your time, you can stop her at some point. But usually they will be the role players will be instructed just not to waste your time a lot. Okay. One of the non-verbal communication with the patient while she is in labor and she is contracting, please stop talking during the contractions. The patient will not listen or understand or respond to you while she is in pain. You may think how the patient will be in pain in the exam. Yeah, she will come. She's sitting on the chair. She just, you know, pretending that she's in labor, and she will just make sounds that she is really pushing, and you know, she will you will feel she's in really pain. And in the station she may got one or two contractions while you are sitting in front of her. Please, these 2 minutes of contractions are counted in the time of the station. Please don't speak at all during the time of contractions. And once the contractions is out, like if it is already eased, you can like encourage her, well done, well done, you are almost there, you did all the work. We may need to guide your baby just with a kiwi cup or a suction cup just to help your baby deliver, but I can see that you are doing amazing, you know, like that. So that's one of the communication as well. What about the visual communication? Visual communication here in part 3 exam is to draw to the patient. Uh, what to draw? Sometimes if you want to explain about ectopic pregnancy, the patient can't imagine how the pregnancy can be outside the womb because they don't know what are the fallopian tubes, what is where is the womb, where is the pregnancy should be, like that. So you need to draw a like diagram to show her, this is the womb, this is the tube, these are the ovaries, the pregnancy is happening here and should be moved to be inside the womb. For some reason it will stuck in the tube and this cause blah blah blah, and then she will be happy. um, I think drawing things will simplify the information for the patient, and if you can draw in each station, that will be the best thing ever you can do. So please train yourself on drawing things. Like, if we are speaking about endometrial ablation, for example, you draw a uterus and draw like the layers of the uterus, so you can tell her this is a womb. The womb usually consists of three layers. The outer layer which is the sheath covering the uterus, we call it perimetrium, and then the middle layer is the myometrium, which is the layer contracting during the childbirth. There is another inner layer called endometrium, which is the lining of the womb, and this is the lining of the womb, which is the layer which shed out with the menstruation. When we go inside, our aim is to burn this lining of the womb and leaving the whole womb without touch, and this will stop your bleeding, hopefully. If you draw the diagram for her, she will understand and she will be on your track. So that's how to communicate with the patient. It's very, very important that you have not to be a hesitant uh, doctor in the exam. You need to keep your eye-to-eye contact. Please don't lose your eye-to-eye contact. Please don't mind the examiner. I keep saying this word because if you mind the examiner, you will lose your eye-to-eye contact. Um, do, Please don't speak during contractions. Please don't speak during the patient emotional dramas. And yeah, one question came before to me. Can I shake hand with the patient? No, please don't. You are not allowed to shake hand with the patient or the examiner. You are not allowed to say hello even to the examiner. You just go inside, say hello to the patient, and sit in your place. Don't touch the patient. Don't shake hands with anyone. Okay? Please don't use medical terminology. You have to be in a very simple language without any medical jargons, in the patient who can understand you. Don't forget to introduce yourself by name and rule, and be confident. Name of the patient is very important in the communication, and so on. It's just a matter of training. You have to keep practicing all the time, and you will get used to it. Okay, thank you. If you have any question, please write down in the comments and I will answer you soon. Thank you.